The first central venous catheter that we're going to talk about are non-tunnel types. These are inserted through the skin directly into a large vein. They are inserted through the subclavian, jugular, or femoral vein, and then advance to the superior vena cava. They are sometimes referred to in the clinical setting as a triple lumen, but these non-tunnel catheters can be single, double, or triple lumen. So when we look at these catheters, they're generally placed at the bedside by a physician or in the vascular radiology lab, or they can also be placed in the operating room. Once this catheter is inserted, the tip does reside in the superior vena cava, and then it is sutured in place. It is important for us to know that as nurses taking care of these lines, we need to make sure that an x-ray is done and placement is confirmed as to where the tip of that catheter is before we use that line. We will have certain protocols that are in place related to flushing these lines as well. So again, protocol will be that these lines are flushed at least once a shift and then before and after each use. These catheters, because of the high chance of infection, the ports are cleaned with chlorhexidine and not alcohol. And again, it's going to be a very vigorous scrub for these. We need to make sure that we are doing aseptic technique with these lines at all times because of the high risk of infection. When we do flush these lines, it's also important that we check for blood return. And when we do this, we're going to demonstrate this in the lab for you, but we're going to, again, clean with the chlorhexidine, attach. All these lines will have side clamps on them. And again, we'll discuss that more in the lab. The side clamps are really important because, again, where this catheter sits, there's a high chance that the patients can bleed or develop air embolus. So we make sure that that side clamp is clamped at all times. We'll remove that side clamp and we will draw back to get a flash of blood to make sure that the catheter, again, is in place. And then we will flush with a full 10 ml syringe of fluid. And the way that we flush these lines is through the push-pause method. And using the push-pause method causes turbulence in the line and promotes removal of any debris that can adhere to that catheter. So it's important to remember that when we do flush these lines, if we do pull back and don't get blood return, we should not force a flush through there because, again, there could be a clot at the end of it, and we want to make sure that we do not send that blood or send that clot out systemically to the patient. It's also important to know that we only use a 10 ml syringe on these catheters, nothing smaller. That is, even if we're given medication or flushing. And again, the reason for that is the excess pressure of the smaller diameter syringe can cause that catheter to rupture. The next catheter that we're going to talk about is the peripherally inserted central catheter, referred to as the PICC line. So this is inserted in the basilic or cephalic vein, just above the antecubital space. Then the tip is advanced to the superior vena cava. We see this a lot of times in the clinical setting, especially when patients need to go home on antibiotics or certain types of medication. And the reason for that is that this catheter can be in place for a longer period of time than the triple lumen catheters that we just previously spoke about. Again, with these catheters, they can be single, dual, or triple lumen. They can, as stated, be used for months, often at home. Again, when we look at patients that have a PICC line, we have to remember that this is a central catheter. So again, insertion is generally done in the vascular lab or can be done at the bedside by radiology, under ultrasound, guided ultrasound. We do have to make sure, again, just like with the other catheter, that we do get an x-ray to confirm where the tip is prior to using. Again, only use 10 ml syringes as discussed previously with the other central venous access device. And you could see that with this one, because of where it is, we want to make sure that we do a limb alert for this patient, okay? Meaning that we don't want to do any blood pressures or anything on that side. And you could see here that this line is attached. This is not sutured in, but we use what is called a stat lock for this. So again, when you're out in the clinical setting, take a look to see if you could see anybody with a PICC line, and then look up to see what their protocol is in regards to their care. But the main thing being, again, the same safety things. Never use unless you have an order after an x-ray has been done. Tunneled central venous catheters are inserted surgically and threaded under the skin to the subclavian vein and advanced to the superior vena cava. Because the catheter is tunneled under the skin, it enters the vein and decreases the chance of resident bacteria on the skin reaching the bloodstream. So again, decreased risk of infection with tunneled central venous catheters as opposed to the other catheters. You could see, again, they can be single, dual, or triple lumen. These do stay in place for a longer period of time. They can be in for 1 year or longer. And some examples of what a tunneled central venous cath would be that you may see in the clinical setting would be a Hickman catheter, a Gross hang, or a permacath. And we sometimes see these with our dialysis patients, okay? And again, they would be treated like any other central line, and we would make sure that we use only a 10 ml syringe on these catheters as well. Implanted ports are small chambers placed in the subcutaneous pocket in the anterior chest or forearm, and catheter enters into the jugular vein. So with these, we generally see sometimes in patients who will need long-term therapy. So sometimes our cancer patients, we may see these implanted ports in, or someone who's going to require long-term medication. So sometimes you may see these in the clinical setting. What we should do is, ask the patient if they have them. And if they do, at that point, we can access them. To access them, we use what's called a Huber tip needle. It's a non-coring needle that enters through the skin right into that area within the catheter. And there are certain protocols in place for accessing and de-accessing these ports. Again, if a patient does have it, we should be using it in the clinical setting. You want to look at the protocol. And this is a central venous access device. So again, all of the things that we mentioned in regards to you only using a 10 ml syringe on chlorhexidine and all that would be needed to be done within the clinical setting. When we look at insertion of a central venous catheter, we may be asked to assist with this insertion at the bedside. It is important to remember that this is a sterile procedure. Okay, the client will be placed in a supine or Trendelenburg to dilate the neck vessels and shoulder vessels, which makes insertion easier and decreases the risk of the patient having an air embolism. The client must also turn their head from the site of insertion and remain still. If the client is not able to turn their head, they will need to put a mask on. Okay, again, to prevent infection, and everyone in that room will also have a mask on at that time. The client may be asked to do the Valsalva maneuver during insertion. Again, this is going to produce a positive phase in the central venous pressure, which will decrease the chance of air entering to that circulation. So I want you guys to go back into the book and look and see and read this actual procedure, where you could see where they go in with the needle first, then they insert a guide wire, and then they do the catheter over that guide wire, and it will make sense to you the different the reason why the patient is placed in Trendelenburg and why a Valsalva maneuver is done with these patients. When this is all done, again, to check for accurate placement of that catheter, an X-ray or fluoroscopy needs to be done, again, to verify where that tip of the catheter is before we are able to use it. And as stated in, previously in this PowerPoint, once they do get that catheter inserted, they will suture it in place and then apply dressing to it. When we look at the complications of central venous catheters, the first thing we see is pneumothorax. Again, a pneumothorax can occur on insertion of that line. Again, these patients are first accessed with a needle, and then as stated, you put a guide wire in there before putting the catheter in. So sometimes that pleura can be punctured during the actual insertion. This may not always be seen initially with the first X-ray that's done. So again, you want to be aware of signs and symptoms of a pneumothorax to make sure that we pick up on that quickly. Another complication we see is infection. Again, with infection, we want to make sure that we're checking that site on a regular basis to make sure that there's no redness or any drainage or anything related to it. We did say that our triple lumens have a higher chance of infection more than our PICC lines. So again, making sure that that dressing remains clean, dry, and intact at all times, that we're assessing that site, and that we're using aseptic technique every time that we access that catheter is very important. Catheter migration is another problem that we see. So when we look at this, we know that the tip needs to reside in the superior vena cava. So if we were to see migration, we might see inflammation within that tissue. So again, we're going to look at if we have somebody with a triple lumen in the jugular, we're going to make sure that we're looking at that neck to make sure that there's no swelling or anything. And then also we're going to, with PICC lines especially, we're going to make sure with them PICC lines that we're looking to make sure, because we said they're not sutured in, so they can easily migrate and be pulled back. So again, checking that tissue around to make sure that everything is okay, that there's no swelling is very important. Another problem we see is occlusion of the line. So we had mentioned before that, with our flushing protocol, we want to pull back, check for blood return prior to flushing. So if we pull back and don't get blood return, we do not want to push through because we're concerned that that line can be occluded. Sometimes people will think that they can, even if they pull back and don't get blood return, but can flush it, it's okay. It's not okay. The concern is that there could be a clot on the very end of that tip that we can push through. So again, making sure that we flush this on a regular basis and that we keep the side clamps clamped will help with prevention of any type of occlusion. Hemorrhage. When we look at hemorrhage, again, this isn't a very large vessel and we worry about the patient bleeding. So that's why we want to make sure them side clamps are always clamped on these lines and that the end caps are very secure on there. Pinch-off syndrome. So when we look at pinch-off syndrome, again, this is where that line gets compressed between the first rib and the clavicle. So this just sometimes happens with patients just in the placement of the line. So with that, sometimes if you don't get initial blood return, what we ask you to do is have the patient just shrug their shoulder a little or raise their arm to see if at that point you're able to get blood return and flush it. And then the last complication we're going to talk about is air embolism. Again, we know that air embolisms can kill somebody, okay? And this can occur during insertion. It can occur when the caps or tubing is being changed, so we need to be very careful. Let's think about what signs and symptoms might we see if somebody had an air embolism. I want you guys to think about that, okay? And then how would we treat this? Well, again, if the patient does develop an air embolism, we're going to position them on the left side, head of the bed in Trendelenburg so that that air will rise above the pulmonary artery, okay? And we're going to put this patient on oxygen and notify that MD right away. So now let's do a little bit of review about the central venous access devices. The types that we talked about were the non-tunneled, okay, sometimes referred to as our triple lumen catheters, our PICC lines, again, that are inserted in our upper arm, our tunneled catheters, which are threaded under the skin and done surgically, as well as our ports, which are also done surgically, and they are under the skin. Correct size and solutions for flushing. We said that all of these catheters need to be flushed with a 10 ml syringe. Again, the smaller syringes exert too much pressure on these lines and can cause it to rupture. The general solution that we use is going to be normal saline, okay? You will see that some out for patients who have lines at home, they may use heparin, but it's generally not used in the clinical setting. When we look at managing these lines, again, we're going to use medical and surgical asepsis. So on insertion, we're going to use surgical asepsis. Flushing, we're going to use medical, and then with these dressing chains, we're going to use surgical asepsis. Again, the most important thing is making sure we keep this line as clean as possible with insertion, dressing changes, and anytime we access this line. When we look at interventions to identify and minimize complications of central venous access devices, we know we worry about with these patients infection, air embolism, clotting off, and bleeding. So we talked about with infection, okay, making sure that we use that asepsis anytime we're accessing this line at all. You will see that national patient safety goals is that we have central line associated bloodstream infections. And with that, there's certain things that we do in the clinical setting to make sure that these patients don't develop infections. One thing is that these patients get a chlorhexidine bath every day. Another one is that the dressing is changed anytime it's soiled or every so many days, as well as the end caps. Another thing that we do is making sure that these lines are flushed every 8 hours and that we're using chlorhexidine before accessing these lines. So when we look at TPN, total parenteral nutrition, we know that this is only given via a central line. Okay, this is not something that we give peripherally. And why would somebody be getting TPN? Again, IVs do not provide sufficient calories or protein to meet our body's requirements. So when we look at TPN, the goal of TPN is going to be to improve somebody's nutritional status, to establish a positive nitrogen balance for these patients, and to try and help maintain muscle mass, promote weight maintenance or gain, and enhance healing. When we look at TPN, which we'll talk a little bit about further on in these slides, they have a lot of additives. They're going to have calcium, magnesium, phosphorus, and sodium chloride. Again, all the different vitamins and nutrients that we would are going to need for patients who are not taking in any type of food. So when we look at TPN, we have to think about what patients are candidates for receiving TPN. Again, when we see, we want to first start with internal feedings, should be attempted first prior to TPN, because this is going to assist with maintaining the mucosal integrity of that GI tract. And it's going to have fewer complications than TPN, which we'll be talking about later. So when we look at patients who are candidates for TPN, it's going to be patients who oral intake does not maintain an anabolic state. Okay, so again, these are going to be patients who are unable to ingest 50% of the daily required calories and nutrients within 7-day time frame. That's for well-nourished patients, and in a 3 to 4 days for patients who are malnourished. Okay. Again, we can see that it can also be used for patients who are unable or unwilling to take in nutrients via the GI tract. Okay, and that might be some of our patients with anorexia. Okay, patients with prolonged NPO status after surgery. Again, or sometimes it's, that patients need higher caloric intake to help with healing. Sometimes we see with our burn patients, HIV patients, or cancer patients. Complications is a big concern with TPN. The first one that we think about is infection. Again, we know that TPN is only given through central lines. So again, a complication of having a central line is one thing. The other thing is that TPN is very high in dextrose. And this causes the solution to be a good medium for growth and pathogens for bacteria to grow. So when we look at, because of the sign of infection for these patients, we always want to make sure that we're using aseptic technique when we're hanging this medication, that we're checking the site on a regular basis. We're making sure that the solution is changed every 24 hours, as well as the tubing being changed every 24 hours. When we look at another complication is hyperglycemia. And this is due to the high percent of dextrose in that TPN. You will see that when patients are started on TPN, that you will see that they start at a lower rate, and they generally will increase that rate slowly until they get to a set amount that they want. Okay, and this gradual increase gives the body time to increase its insulin production to manage that increased dextrose in the TPN solution, because we are concerned that these patients will become hyperglycemic as they do get started on TPN. So a lot of times we will see that these patients are put on a sliding scale just to sort of give them insulin if they need it to help control that hyperglycemia that they may have. These patients are also at risk of developing hypoglycemia, and this can occur when that bag is empty or a bag is not available. So we always say that if this happens, because again, this is medication, this TPN is something that we wean down. We don't just abruptly stop it. So if the bag does run dry, we will hang 10% dextrose for these patients, again, to help prevent that hypoglycemia. And again, another thing that we do is we make sure that we titrate this medication down. We don't just stop it abruptly. Fluid and electrolyte imbalance. Again, TPN is a hypertonic solution, so we worry about them fluid shifts, okay, especially with the electrolytes. So the electrolytes are going to be checked every single day for these patients, okay, and that is actually how they're going to determine what the patient is going to receive in the TPN for the following, for that evening. Allergies. Again, we want to make sure that patients don't have any allergies. And the biggest concern is not necessarily the TPN, but to the lipids that we may hang, that we'll talk about in the next slide. And this, because they're sort of like a fatty substance, we're concerned if patients are allergic to eggs. So that's one thing we have to think about. And then incompatibility. So when we look at TPN, TPN should not be run with any other medication. Okay, TPN has its own designated line. TPN will be run with a filter, and we will show you what that filter looks like in lab. And the only thing that will run with TPN are the lipids, okay? And the lipids will run with the TPN, and they will connect at the Y site below the filter. But they are the only two things that will run together is TPN and lipids. Nothing else will run with this medication. This is just to give you an idea of what a TPN label will look like. Okay, so if you have seen TPN in the clinical setting, it usually comes in a very large bag, and it's generally yellow. It's not floor stock. It's not something that we keep in the back room. It is, again, made specifically for that patient every day based on what their lab values are. So with that in mind, you can see that it has all the different electrolytes and everything in it. So these TPN bags generally are hung in the evening time and go through the night. So the bags will come up in the evening and be hung again, dependent on the patient, each individually, their specific order. You'll see that we need to compare the label on the bag to the order to make sure that we have the right bag for the correct patient. The bags are generally 2 to 3 liter bags, and they should run in over a 24-hour period. Again, every time we hang TPN, we're using new tubing and a new filter. Lipids. When we look at the lipids, lipids are generally in their own bag, and you're going to use separate tubing for them. And as stated previously, it's going to run below the filter, but will run through the same line in the central venous catheter.